Okay, so we're going to discuss today the introduction to paramedicine. This falls under the standard EMS systems for the preparatory educational standard. The competency we're trying to reinforce here is comprehensive knowledge of EMS systems, the safety and well being of the paramedic, the EMT, the AEMT, the EMR, and the medical legal issues contained within, which is intended to improve the health of EMS personnel, patients, and the community. Within EMS services, the paramedic is the pinnacle. They are the highest level of care within the pre-hospital setting. They are defined as, let's see, the paramedic is considered to be a highly trained, healthcare provider and they provide comprehensive, compassionate, and efficient pre-hospital health care. Or pre-hospital emergency medical care. So to fully understand where this comes from, and we all have been there because we've all come up through the ranks at the different levels of EMT, AEMT. Some of us started at EMRs or first responders. We know there are different levels. We're going to delve into that just a little bit. So as we discuss the levels of EMS and the providers, we have to understand a little bit about where they come from. So EMR, or the former first responder, essentially immediate life-saving care to critical patients. CPR, a little bit of advanced first aid, a foundation in airway management. EMT, basic emergency medical care, intro to pharmacology, intro to airway adjuncts, and the first level for transportation for critical and emergent patients. Now, in some areas, EMRs can transport or at least drive. EMTs generally have been the standard of the basic standard of care for transportation of critical and emergent patients. And as you can see, the knowledge base tends to grow as each level expands out. AEMT, or the Advanced Emergency Medical Technician, basic and limited advanced medical care. So you are delving deeper into pharmacology, a little bit more into airway control, mainly into pharmacology, electrical therapy, as in defibrillation and things like that, cardiology. You're starting into cardiology and recognition of rhythms and treatments. And then paramedic. Now you can see this is a graphic that I've borrowed from multiple places, multiple locations. You can find it on a lot of areas. That does a pretty good job if you think of the depth and the breadth of knowledge. Starting from basic, very basic, to starting into a little bit more advanced with the EMT, getting into more advanced, getting into advanced life support with the AEMT, and then finally with paramedic being the pinnacle or the highest level of pre-hospital care certification or licensure, depending on where you're at. The paramedic is critical and emergent patients, and complex decision making. So everything that is encapsulated within EMR, EMT, AEMT, plus the ability to make critical, complex decisions and treatments while transporting. This is patients in the pre-hospital setting and in interfacility transfer as well, critical care transports. The modern paramedic encompasses the disciplines of healthcare, public health, and public safety. We provide emergency care in the out-of-hospital setting or out in the public. We make accurate, independent judgments with generally incomplete and less than accurate information. We also carry and maintain appropriate licensing and or credentialing, meaning our state certification, our national registry certification or licensure, our ACLS, PALS, CPR, all of that is combined into this, and we are, as we all know, responsible for maintaining these. Whether we get help from our services or not, it is ultimately our responsibility as the individual holding the credentials to maintain those. So as you see, we've got healthcare, public health, public safety, and EMS falls in right here. We embody all of them. We touch on each and every one of these. Of course, you've got the emergency room, you've got convenient care locations, you've got all of these other things. But to the level of care that is being given in the pre-hospital, EMS is it. You may be asked to give a presentation on health education. You may be asked to give a talk on public safety talk on the dangers of riding a bicycle without a helmet, elbow, and knee pads, or driving in a car without a seatbelt. You know, these all fall under public health, under public safety, under healthcare. We respond with 911, with police department. We take care of people, we give medications, we reverse reactions, or attempt to anyway. We give quality healthcare, quality advanced healthcare in the field. We do much of what the emergency room does in an area less than a quarter of the size of a standard trauma room and less equipped. We do those things. We are in the public. We should be in the public. We should be educating every day. We should be stewards for personal health and well-being. A lot of us aren't. I am not a poster child for health and well-being, but I should be. That is a responsibility that I have not taken seriously, not only to myself, but to my career. It's easy to talk about it, not easy to hold yourself responsible for it. We function under a medical director. We function under their license. Whether we are a licensed paramedic or a certified paramedic, there is a medical director. There is somebody that gives us the protocols and the guidelines under which we make our decisions. We have knowledge and we have skills, but they also provide direction. The medical director tells us what we want to do. It is our responsibility to know our protocols, to know our guidelines, to know our scope of practice per our medical direction. The state of Kansas does not have a cap on paramedic education, or not education, sorry. We do not have a cap on the paramedic scope of practice. It is up to our local medical direction. Whatever they are willing to sign off that we are, and educate us on, and that we are skilled and maintain that competency within that skill, we are allowed to do as long as it is written in the standing orders or in our protocol book. But it functions under their license. They are attesting that they as a physician have taught us and that we are competent in this skill and we are signed off and able to do it. Pericardial centesis is an example. Finger thoracotomy or placement of chest tubes or in the field, something like that. Giving blood in the field. There are services now that are doing that. Their medical director has made sure that their education met his requirements to do it safely. He has signed off on it, and he has created a protocol in which they are allowed to perform that skill and give that intervention. We have knowledge, skills, and attributes consistent with expectations of the public and the profession. The public expects us to know what we're doing when we show up. They expect us to have the equipment and the skills to operate and use that equipment to the best of its and our ability. They expect us to act as professionals and to conduct ourselves as professionals, whether we are on a call or whether we are out in public while on duty. And to some extent, even outside of that, we are expected to conduct ourselves in a professional manner, even in the public, even in our off hours, because people do recognize us. And we are a major component within the continuum of care. We're not the first link in that chain. We all know the chain of life within the AHA. The first is bystander, then calling 911, so dispatch, our response. We're right around third in that link. But we are a major link within the continuum of care. And we are expected to conduct ourselves in such a way. We are a link between resources. If you are in a critical care hospital, little bitty hospital right out here in southwest Kansas, and your patient needs to get to big city hospital 200 miles away, how are they going to get there? We can do a rotor. We can do a fixed wing. Or we can do a ground ambulance. But guess what's on every one of these? There is a paramedic on each one of these steps. We advocate for our patient. We want what is best for our patient, not necessarily what is best for us. Would it be best for me to take a patient at 3 o'clock in the morning by ground after running calls all day on a 24-hour shift or a 48-hour shift? Probably not. But does that patient need to get to where they're going, and does the weather allow for flight? We need to consider, and we need to be knowledgeable of these things. We need to be able to make this decision or to advocate for our patient that this decision needs to be made. Is our patient, they call us for a ground transport, and our patient is actively having an MI, and they are able to fly. So for example, a 200-mile trip, we're looking at potentially 3.5 hours by ground, 1 to 1.5 by helicopter, 45 to 1 hour by fixed wing. Of course, I know weather dependent and other things, these are averages. That patient is activating an active MI. Is it more prudent for them, and weather's clear, everything's equal, is it more prudent for them to take a fixed wing or a rotor over ground ambulance. Yes, they need to be there fast. They need to be there right now. They need to be where the capability is as soon as possible. We need to advocate that for our patient. We need to say, no, this patient is too critical for ground. You have an air ambulance available. We need to talk to our supervisors. We need to be able to and comfortable to go up that chain of command to get those decisions made. We need to advocate. Is our patient getting the treatments that they need? Are we capable of providing those treatments? We need to advocate. If we are able to give a treatment, we need to give it. We need to be able to give it and provide it to this patient. We need to ensure that the patient receives the best possible care without regard to of ability to pay or insurance status. I don't ask my patients, I never have asked my patients, well, what kind of insurance do you have? Because that's going to decide the pain medication you're going to get. Or that's going to decide the hospital you're going to. That's not my decision. That is not my decision. My decision is what is the best treatment for you. And I'm going to provide that to the best of my ability. And I am going to take you to the most well-equipped hospital to handle your situation that is the closest possible, within reason. Can a patient choose what hospital they want to go to? Absolutely they can, if their condition warrants it. Can a family member make that decision? Yeah, to some extent. But again, what do they need? Do they want to go to a small community hospital that's 20 minutes, 30 minutes away? Or do they want to go to and there's a trauma center and they need the trauma center that's 10 minutes away? We're going to go to the trauma center. I don't care if they're doctors at the community hospital, they need a trauma center. They've been in an accident, they need a surgeon, they need surgery right away, whatever the case may be, they're going to what needs to be. This is where our education, this is where our knowledge, this is where our thought process comes into play. We need to be able to make these decisions. Community paramedicine, we'll get into it in a little bit, but that is starting to be a huge thing nationwide. And they are making decisions on this patient can go to the doctor's office. We're going to call the doctor and see if we can get them in. We'll take them to the doctor. They can go to a convenient care. They don't need to go to the emergency room. We make that decision all the time. We don't know it. Well, yeah, you can go with a family member. You don't have to go with me to the emergency room. You're stable enough. Your injuries don't require, or your condition does not require my level of care. Absolutely. You can go with your family member to the hospital. They can wait in the waiting room. ERs ask us in bigger cities, is this person triage appropriate? Meaning, can they go to the waiting room? We make that decision for them because we know what the patient looks like. We're right there in front of them. At the same time, we need to advocate. Is the patient triage appropriate? By radio report, it may not sound like it, and they may want you to do that, but then you need to make the call, no, this patient is not triage appropriate, they need a room. These are just some of the instances, and we'll get into this more. We take part in and we provide public education. And it goes beyond CPR and first aid courses. Every service has a CPR first aid instructor. One of the services I worked for, you were expected to take part in education. It may not have been public education necessarily, but you were expected to precept students. EMT, EMR, AEMT, paramedic, all of them. You were expected to precept them. You were expected to take part in public education activities, going to the schools and talking to kids about how to be safe, that encourage them to wear helmets, elbow pads, knee pads when riding skateboards or scooters or bicycles. Health promotion, eat healthy, eat plenty of vegetables with the kids, less candy, healthier alternatives, participate in injury and illness prevention programs. Again, we're going to schools and we're talking, it's all public education, it's health promotion. We're participating, we're out there, our ambulances are visible. We provide health screenings at health fairs. We do blood pressure checks, blood sugar checks. We do 12 leads for health fairs. We take part in one as part of this program. With COVID changes, I don't know if that's going to happen as much this year. However, we used to do 12 leads at one of the local churches during one of their health fairs called the Day of Service. They provided free medical screenings. They provided free dental screenings, and we took part in this, and we take part in this, and we're proud to take part in this. Mobile integrated healthcare, or community paramedicine that we were spoken about earlier, functions outside customary emergency response and transport roles. What do these guys do? Paramedicine is such a huge, community paramedicine, I apologize. Community paramedicine is such a huge, huge thing. Think of home nursing. It's very much similar, but in different ways. We go in and do a lot of the same things that the home health care nurses do. We go in and we check and make sure that their medications are being taken properly and that they understand what the medication is for. The community paramedic goes to check on frequent flyers to reduce the number of calls and maintain the availability of primary units for full-on emergencies. They perform dressing changes. They educate on how to use oxygen equipment. How many people have you, some of you may not have done this, but some of you may have. How many of you have gone to a home where the patient is on a concentrator and there's a power outage, but they don't know how to set up their oxygen bottles for backup? And so their O2 sats are dropping and you're getting 911 calls during power outages just for providing oxygen. These are some of the roles they take. They respond with ambulances and they help decide, does this patient need to go to the ER or can they go to convenient care? Can we call their doctor's office and get them in for a visit today? Do they just need a med adjustment? Have they missed a med? And the patient has a question. These are some of the roles of the community paramedic. Some of our characteristics of a paramedic. There's multiple, and everybody has their own list. A paramedic has to be flexible. You can't get locked in on one thing and just drive that home, because that may not be the case. Or there may be more going on than what you see on the surface. You have to be flexible and ready to change. That includes protocols, staying up on the latest science, staying up on the latest treatments, and keeping up with publications and keeping up with your continuing education. You need to be a confident leader. You need to be able to make those decisions, stand by those decisions, back them up, but at the same time have the confidence and the willingness to say, I was wrong. This was a mistake. We should have done it this way, or similar. You have excellent judgment. You look at a situation and you can formulate a judgment on what has happened. You can see the whole picture. You develop this, and this develops as you go along. All of these are not going to be instantly attained on gaining your patch and your certification. You're able to prioritize your decisions. What needs to be taken care of first? And you'll see that through testing. You'll see that a lot through testing, is they're testing your decision-making capabilities. You see lots of advice online and in paramedic forums and on Facebook and everything else about how to take the tests, how to make those decisions. What is the right way to do it, to get through this part of it, to get out into the field and start practicing and putting this to use. But that's something you learn through the class and through experience. Once you get out and you're experiencing being a paramedic on the truck for the first time. You're able to develop a rapport with a wide variety of patients. You can talk to the millionaire sitting in his recliner having chest pain just the same as you can talk to the homeless man sitting in the back alley, dirty, covered in crap. You can develop that rapport that they want to open up and they want to tell you what's going on. They don't feel any kind of judgment. They don't feel any kind of anything. They just know that you're there to take care of them. You develop that rapport. You're able to speak to them. You're able to advocate for them equally, and you are able to I'm lost for a word. Anyway, and you're able to function independently. There are times that you do not have medical direction to back up online or in person. You may have to make a decision based on your experience and knowledge and your knowledge of your protocols, your knowledge of your standing orders. This helps in your ability to speak to your medical directors and say, and your ER doctors, because your ER doctor and your medical director may not be the same person. You may do a treatment that you had to make a judgment on, and you go to your doctor and you explain to him why you did this treatment. And they know you know the protocols. They know you know your physiology, your anatomy, your meds. They know you know this, and they trust you and they trust your judgment. It takes time to earn this. It doesn't come in automatically. Allows you to function more independently within and under their umbrella. A paramedic is a true health professional. There's a lot of people, there's a lot of older people. A paramedic is just the guy that shows up, the old ambulance drivers, the old hearse drivers that show up, throw the person in the back, and drive to the ER. We could be that. We could easily be that, but we have more education. We have more skills. We have more knowledge. We have more equipment than that. Those days are over. We give treatment. We diagnose. We give treatment. And we transport our patients to definitive care. We participate in continuing education programs. We will eventually start offering, as you as individuals will eventually start teaching continuing education programs. We review and practice skills and procedures. We hate it, but we do it. A procedure we haven't done in a long time, we need to break out the mannequins and we need to do it. Every service has training materials, training equipment. We need to maintain, especially on the things that we don't do on a regular basis, we need to maintain that proficiency. We do peer evaluations. We talk to each other all the time. We do it unofficially. We do it informally all the time. We talk to each other. How do you think I did on that call? Do you think I could have done anything different? What do you think? How do you think that went? We talk to each other all the time. Our services also perform QA/QI, quality assurance, quality improvement. They run back through our run sheets and through our documentation, and they read it and they say, why did you do this? Why didn't you do this? This was in the protocol. This wasn't in the protocol. This is not to belittle us. This is not to criticize us, but to improve us. We take an active role in professional and community organizations. NREMT, NAEMT, KEMSA in Kansas. There's multiple. There's many professional organizations. There's community organizations, the Lions Club, the Optimist Club, the Shriners. Some of the people take part in Shriners. We are active in these professional and community organizations. Through those that we promote health, we promote ourselves. We promote our services. We promote community health. We promote public health. In addition, we use the National Emergency Medical Services Educational Standards Paramedic Instructional Guidelines within this class. We also use the Kansas Emergency Medical Services Educational Standards for Paramedic within this class. These guide your education to ensure that you are meeting all of the benchmarks of education that has been prescribed through research, through constant continual development, through QA, QI, through participation in research. Whether we know it or not, we participate in research all the time. Your service may not have an active role with a trial of something. We may not have an active role with a certain organization necessarily, openly. However, through our demographics, through our run reports, through our reporting to the to our state trauma, to our local trauma council, to our state trauma council, to the national trauma council, through that chain, we are participating in research. We are showing what our treatments are doing, what is working, what is not working. Look at the recent trend of moving away from spine boards and to spinal motion restriction. That has all come about due to research, showing that we are injuring more people with spine boards than we were helping. That's a very broad overview. But that all comes from our run reports. We'll get into the documentation more, but we take part in research whether we want to or are willing to or not. It happens. We accept and we adhere to a code of professional ethics and etiquette. Some more than others. I mean, it's a fact of life. There are certain professional ethics and there is an etiquette to what we do. We don't make jokes around dead people's family members. We have dark humor. We all do. We all make jokes. Etiquette dictates that that be kept to us. Sometimes our darkness slips in public and we have to excuse ourselves. Etiquette dictates that we do not do that. Small example. We will get into it more through discussion. We don't talk about our calls to other people. Not only is that the etiquette, and not only is that, but it's legal. It's a legal issue. HIPAA is a real thing. We are asked, and to paraphrase a well-quoted EMS, his name just escaped me, Thom, and I can't think of the rest of it, but we are personally invited to the death of family members and to the birth of family members, and in some cultures, that is a sacred honor, and we are personally invited. We need to treat that as the event that it is. I have this poster in a classroom. We need to treat that with the honor and respect that it deserves. The emergency patient is always the primary concern. After ourselves. Of course, safety-wise. We're trying not to feed attention to other people when this is the person that needs our help. We need to focus on them. Many of us are cross-trained or will be cross-trained. There are many firefighter medics. There are many police officer medics. Participate in rescue operations, directing traffic, and other tasks as needed on an emergency scene. If you're a third service and all you do is and all you do is EMS, emergency medical services, that's all you're going to do. You're going to treat your patient. Your focus is not traffic control. Your focus is not whether they committed a crime or not. We don't care. I'm here for the injury. I'm here for the illness. I'm here for the condition. I'm here for that person or those people. Rescue operations. As a firefighter, you may participate in rescue operations. You may not be a direct patient care provider. You have knowledge to draw from. You may be asked questions. You may be offering opinions for treatment to the other paramedic that's there. But your role may be blocking traffic. Your role may be using the jaws of life to remove the roof or open the door. You need to remember what role you are that day in some cases. Police officer. Are you a SWAT medic? What is your primary focus?